Wild look, there we go. Good evening, everybody. Welcome to our last rural onboarding session for these last 2 months. We've had some very exciting topics. Don't worry if you've missed some of them, you will be made available we've got a full YouTube playlist with all the webinars that's been happening. I found it's also really helpful to actually catch up on these in the car on the way to work, for example. And hopefully this is a resource that will keep on giving throughout for the rest of the year. We've had lots of very practical clinical topics, and in our 8th week, we always want to move a little bit more to the non-clinical topics. And tonight we're actually going to have an ethics talk that we are very, very pleased to have Prof Parrish here, who is still providing us with lots of support from beyond retirement. So I was telling him I'm going to have to do this slightly in past tense. This is still our bio CV from last year. But yeah, Prof Andy Parrish worked as an associate professor at internal medicine at Walter Sisulu University, here at Cecilia Makiwane in East London. He's specialist in internal medicine, and he's had a 30-year interest in evidence-based medicine and clinical pharmacology. And he's been very involved with the South African Essential Medicine List Committee since 2010. And so keen interest in decision-making, guideline development, and health technology assessment. He also enjoys the bedside use of clinical epidemiology in diagnosis and management, and today is going to take that critical eye, moving it a little bit more towards the ethics side. Prof Parrish has always been a very passionate teacher. We're all very well, he's sorely missed at Makiwane, and he was also very involved in setting up BAMSI, which I'm sure some of you are aware of. That's here. Sort of outreach and regular webinars also for rural facilities in Buffalo City and Amathole districts here in the Eastern Cape. So, Prof, we're very happy to have you with us, and I'm going to hand over to you now.
Yeah, thanks very much. Thanks for that rather long introduction, because it says stuff that I've stopped doing being a retired old man. But anyway, let's see what we can do with the topic we've got here now. And I'm going to be covering an area which I think is quite interesting in the sense that rural ethics and ethics in general should be the same thing, but there probably are a few differences. Yeah, let me get going then. Can you see my slides?
Yes, Prof, very clearly, and we can hear you.
Okay, good. Right, let's get going then. If I can advance them, will be the next thing. Right. Okay, so then the idea here is to cover a couple of things around ethics. You know, a lot of talks about ethics tend to be either focused on the structure of ethics and the principles behind it and applying those principles to cases, or about you know, the ways things go wrong and the rules and things that have been set up around that. I want to try and integrate those two things and sort of wind each other around the concepts as well as the issues that apply to rural practice. So remember that ethics is a map rather than an actual route that you have to follow every time. It tells you how to get from A to B, but not necessarily the best way to get there. And it has issues around protecting patients, helping patients navigate care, helping patients make adequately informed decisions. And it also has issues around mistakes and malpractice, and the issues around gaps in care. The thing that I thought would be challenging and worth discussing, particularly this evening, is the issue around moral injury and burnout, and how that interleaves with ethics in general, and how we protect ourselves against the system, and when the system is giving us a hard time, how we protect patients against our issues with the system. So just a very brief one. I think this is the only sort of theoretical slide here. There are a lot of different frameworks, and we always think it's very straightforward if we are placed straight within one framework, but these do overlap. And the sort of familiar ones are utilitarianism. What's morally right is what generates the best outcome for the largest number of people. So that's a sort of pretty straightforward one in one sense, but sometimes difficult to work out what is the best outcome and what is the largest number of people. Deontology is absolute moral values, relatively straightforward. Virtue ethics is about trying to make yourself behave better and behave in an ethical way based on those principles. Then rights-based ethic really is looking at making sure that all those things like beneficence and non-maleficence and all those things are actually being followed, as well as constitutional rights within a country. And then care-based ethics is what is moral is that which promotes healthy relationships. So all of those things can be dipped into, or you could stick to one only. And some of the biggest debates come, obviously, when people, without really knowing they're doing it, flip from one framework to the other, or have a debate with somebody using a different framework. And it is worthwhile scratching back down and making sure that you're on the same page before getting too upset about what seem to be different values. So all of these terms are things that you're familiar with. I'm not going to spend longer on them other than to touch on two that are there: feasibility and distributive justice. Now, those are the things which often come to play in rural practice. Are you doing what you can do? Are you being as using as much integrity and sticking as close to those values as you can, and get delivering quality care, but still within what's actually feasible? So what I'm going to do then is run through a series of cases. Now, you're invited to interrupt at any time if you want to, or we can bounce through them, and then you can make a few notes and talk about what is close to your heart from any or all of them. They're all cases that are sort of real in the sense they're things I've come across. I've obviously changed context to some extent to make it unidentifiable, and they all are things which I hope will make you think a bit. Maybe it is worth thinking about how they make you feel also as we go through them, and how would you handle those feelings, because that comes back to the issues around burnout. So this comes from an article on the ethics of place, which was about looking at whether perspectives on ethical issues differ depending on where you're working, from the US. And they asked a bunch of questions. And all I've done here is taken the questions that they were asking or trying to research, and using them as effectively headings for case reports. So we're going to cover the sort of 6 things that are discussed there, and see if any of the case reports give us any ideas about what challenges we face. So the first one is a neighbour's daughter presents with an asthma flare. I'm working in a small rural hospital, and this person's daughter from seeing her over the fence and chatting to the dad and that sort of thing. She has a peak flow of 60 and a paradoxus of 20. 5, you're in the emergency unit and you look after her, and at the end of your shift, she's actually a bit better. Peak flows up to 210, paradoxus less than 10. She smiles at you and says thank you, but you kids think it might be a good idea to keep her for the night, as she's still quite wheezy and you're worried she might have a sort of backsliding episode. At 2 a.m., according to the notes, the doctor on duty's phone because she's restless. He prescribes further nebs and sedation telephonically. And the next morning, you asked to fill in her death certificate. I'm going to give you all the cases first, and then we'll unpack each of them a little bit. So the second one is your hospital superintendent has been approached by a drug company from another country to assist with recruiting patients in a trial of an antifungal. Trial's got ethical approval in that country, but no local institutional approval. Your institution doesn't have an ethics committee. The trial pays 10,000 Rand per patient recruited, but is expected you and your colleagues will do the informed consent and paperwork. The third case, a hospital colleague runs a private practice in town as well. On discharging patients from the ward, he refers them to his own practice for follow-up rather than to the hospital outpatient department. This reduces load and provides some continuity of care, but the nursing manager points out that he's recruiting income, generating patients from those in the hospital who could be seen for free in OPD. We're nearly halfway through these cases now. 58-year-old diabetic man presents with recurrent epigastric pain. He's been seen 3 times in the past week by a GP colleague who does sessions in your hospital. He's been given analgesics, a proton pump inhibitor, and amlodipine. He's now in heart failure, and the ECG shows an extensive anterior MI. And there are multiple similar instances involving the same colleague. And on the same sort of line about where we're going with boundaries and things, 34-year-old woman with a CD4 count of 360, newly diagnosed as HIV positive, started on INH prophylaxis, cotrimoxazole, ARVs. All her medicine, according to her, was to combat the HIV, and she presented 7 days after the onset of a Stevens-Johnson syndrome and dies of fulminant septicemia the following day. And you can ask questions about the difference between treatment and prophylaxis, and should you have broached that with her. And she was also given steroids in high dose a week ago when she first presented. What do you think of that from an ethics perspective and from an evidence perspective? So we're nearly there. It's a couple more. On a Friday, a 65-year-old lady in your ward with a severe dilated cardiomyopathy asks whether she'll ever be well enough to go home. Her heart failure is getting better, but she's quite anxious. And then on the Monday morning, she's smiling and more relaxed, but she's in worse heart failure. She says her family brought her some extra care from home. And the second last one is a 25-year-old man unconscious after assault. A senior colleague makes no mention of limb weakness, but when you see him the next morning after admission, he's got a dilated pupil on the left, a right hemiplegia. He's still not completely unrousable, and you have him managed. You accepted at a site with a CT and neurosurgical facilities, but he passes away during the 6-hour wait for an ambulance. And then rather distressingly, a nursing manager remarks on the long delay between admission and death and suggests that you could have phoned earlier. And I think this is the last one. A 23-year-old diabetic woman presents with clear features of DKA. You haven't got ability to monitor serum pH. Usually potassium results take about 24 hours to come back. She doesn't appear to be settling with your initial therapy. And when you refer to the regional hospital, you're told there's a bed shortage, their blood gas machine isn't working, their lab service is running with a more than 24-hour turnaround time, and you are basically told that this is public health and maybe you should get on with it your site. So where does this all take you? I mean, I think I've given you a bunch of cases, all of which are things that have happened. They all are real, and they all elicit questions and thoughts. And one of the issues is that a lot of this thinking about these sort of things leads to moral injury. And I'll come back to what that might be, but just to remind you that in most countries, it's seen as a real issue. And in one survey in the US, for instance, over half thought they had a reasonable optimal work-life balance, but nearly half thought they didn't. And all of those things can then have burnout type effects. So it happens, moral injury, when individuals violate or witness violations of your deeply held beliefs and values. And one of the issues really is that sort of moral challenge causes distress. In a lot of folk, that resolves over time, and one develops coping skills for it, but not always. And it obviously depends on the sources of those moral challenges and the person involved and the support they get. But the bottom line is quite a few of us end up with burnout and compassion fatigue. There's withdrawal, there's cynicism, avoidance behavior, and just depersonalization and a perception that you really aren't doing much good or achieving what you could be, or doing what you set out to do when you studied medicine. You just feel generally exhausted. And it presents with all those things, which I think you're all familiar with, so I'm not going to focus too strongly on the ones that puzzled me a little over the years have always been anger. Shame and regret and alienation and grief all make sense. Insomnia makes sense. But the anger about the system is one of the ones that is quite easy to understand in one sense, but quite frustrating in another, because it isn't that easy to fix. So it's all stuff you know: high workload, inadequate support, resource inadequacies, and when patients just don't do as well as you would hope they would. All of those things sort of join together to make a set of predisposing factors. And other things are discrepancies between your work ethic and those of your colleagues. Colleagues may be less enthusiastic about work. You may feel isolated. You may feel there's a big disjunction between what's achievable and the relatively low expected standards of care. And there's often a perception of lack of agency. You can't seem to fix anything in the system. It just seems to be overwhelming you. So that's the sort of background to this. Now, this is where I don't mind if you pop in with some questions, but as I say, you can also just write them down and I'll just make a few comments on them as we go through. So this is the first one. This is this business about boundaries and where you are. And as you're working in a big hospital, far away from the community it serves, as is often the case in many of the teaching hospitals in our country, you may end up not being terribly familiar with the thing that confronts you in a rural practice, where the patients you treat are also the people in the community that you're living in. And that brings a sort of immediacy to the whole business of care, and makes it quite difficult in a way to separate the two in some situations. But also, when things do go wrong, there's a huge sense that you're part of a community where things have gone wrong, as well as being the one that is a lead in understanding why that should have happened. The second boundary here is around the issue of a colleague's approach to a patient who's been referred to him over the phone. There's all sorts of different approaches to this, and in retrospect, this one seems to be wrong. If it all had gone well, it wouldn't have been an issue, perhaps. But when things do go awry, as happened here, it seems really a pity that you didn't go and check the peak flow and assess the patient and then prescribe something more aggressive, or perhaps looked into things more closely than just prescribing sedation. So those are the sort of things that are what ifs, and they become very common in our practices, but also what ifs linked to these are my neighbors are quite poignant and sometimes difficult to handle, and particularly when you are then asked to be the point person in terms of death certificates and negotiating with the family. So what I put this one up is just to remind you that rural practice is different. It does have these issues around it, and it doesn't mean the ethics is different. It just means that how the stress happens is different, and also how one thinks about things may be different. It may be actually better at thinking about things, not necessarily worse, if you are a part of a community that a patient belongs to. So there's pluses and minuses to all of these things, and the pluses might be actually quite strong. The difficulty sometimes, and this is again a more general thing, is separating medical advice from social spaces and the ethics around that, and how you actually manage those boundaries can be quite fraught sometimes. So this one's relatively straightforward. This is number 2. Really, it's about where's the ethical oversight for this sort of thing? And flying solo and trying to run a trial without local ethical approval is not a great idea. But the folk who are involved in that process need to have enough knowledge of the issues around good clinical practice to be able to say, hang on, we need this and this and this and this before we can go on. And the problem is if the guardian, if the leader is the one who's actually at issue there, it can be quite difficult when the politics of seniority to, as a more junior member of the group, try and resolve this thing. And the answer, as usual, is around ethics being a group endeavor, trying to get people to sit in a group and share thoughts about this and find a way forward rather than just taking the boss has said, therefore I must type approach. But again, I think it's something you might want to discuss. So this is a relatively straightforward one. This happens in all hospitals, in all healthcare environments, in GP practices. It's a question of a slightly different approach, which from one extreme seems terribly wrong, and another extreme maybe isn't such a bad thing if he's actually doing a good job in his private practice and knows the patients and, it's part of the community. So like a lot of these ethical things, it's quite straightforward on one level. It's very easy to see other ways around. And again, plotting a way forward here would probably entail some discussion and some thinking through and some putting some values on the table rather than just trying to either ignore it or get very upset by it. It does raise issues that, do get further into the question of quality of care, though. So one loses track of what's actually happening to those patients. Is that a good thing or a bad thing? You can expand all these questions into very tortuous arguments, or you can keep them relatively simple. So this is the one about the chap who had a heart attack after a lot of symptomatic therapy. And again, I'm not putting this one up for anything more spectacular than to say that we have all encountered this situation. And if you haven't yet, you will, where, clinical behavior and clinical acumen are on a spectrum from a simple mistake, somebody simply not knowing something, and then a sort of slightly deeper thing where there seems to be a pattern, and there's a pattern of concern, and how one approaches that again is usually involving getting a group together, planning a strategy rather than trying to fly solo. It is certainly something that needs to be looked at, and leaving it unresolved can be difficult. Trying to resolve it can be enormously time consuming and frustrating, and not always as easy as it would appear when you discuss these things at med school. And it does have a cognitive burden, and that's the other thing to just say. And again, so those are the sort of things which can actually contribute to job satisfaction amongst other people. So the last one on these sort of clinical ones, Stevens-Johnson after multiple medication, and just thinking about how we counsel people. When you have enough time, is it important to counsel on the difference between treatment and prophylaxis? From one side, it's taking a bunch of pills. From the other side, it's knowing the difference between treatments which are going to definitely make her healthy, and treatments which might avoid an illness but have a very low probability with that CD4 count of actually in her necessarily improving outcomes. It doesn't mean they shouldn't be given, it just means that you need to think about it. And the same issue arises around Stevens-Johnson and steroids. The fact is she came in with fulminant septicemia. That might have happened if she hadn't had steroids. Steroids might have helped her. They might not. There's no right or wrong answer with a outcome that was suboptimal, but it's the sort of thing that raises the question of how well you should know the data before just giving them. Do you need to know how well they work? And that we really don't know how well they work is actually the short answer. And does that make it easier to make it a prescribing decision or more difficult? All of these are things you could think about. And then there's also the question of what's the right amount of information for each individual patient. Do we know enough? How much do we think we need to know? Have we got it right? And how do I know if I've got it right in terms of the amount of information I have? So those are a whole bunch of questions which we can also explore. Again, most of us have to practice within what we've got, but it is worth just sometimes scratching the surface and thinking, maybe I don't know this as well as I thought I did. And that can apply to really straightforward things. So this one is a lovely, straightforward one. She's had a cardiomyopathy. She had a happy weekend with the family. A lot of her spiritual and other distress was settled, but the consequence of that was some medication probably changed hands. And one of the things that's in a lot of so-called herbal medication are sort of Western style medication like non-steroidals, which combined with salt and other things are not necessarily the best thing for somebody with heart failure. And the debate really is for her total overall health status, what is good and what is bad, and how can you find a medium solution to this sort of problem where her distress is handled, but maybe her heart failure isn't exacerbated to that extent. So I'm going to I think this is fairly straightforward. Sociocultural issues are discussed. The determinants of health you guys are getting much, much better at talking about than folk were 10 or 15 years ago even. But even so, it's sometimes quite difficult to operationalize some of that finding of sort of the halfway mark, as it were. All right. So this last one then is about curtailed agency, the second last one. Guys who's basically been bumped on the head, he's probably brewing a subdural, and you recognize it and do what you can about it. And the end result of it is a bad outcome and a suggestion that things could have been better if you'd done more. And none of those things are uncommon or don't happen. The issue is how one handles it. And do you start a fight with a senior manager? Do you try and look at ways of avoiding this sort of thing in future? And do you turn it into a teaching episode? And how do you actually deal with the issue of a potentially reversible bad outcome? And the problem is a lot of us will get frustrated by that sort of thing. There's so many of those things that are fixable in other environments, but just go wrong, and you're left wondering, is it possible to do anything in this situation? So this is the last one. I hope I'm not bewildering you too much, and I hope you're getting some things to talk about. But basically, it's a straightforward thing. DKA, either manage yourself or manage in another, in your regional hospital, and the regional hospital says you can do as well as they can, and that it's the fault of the system. So it is difficult to know what to say about that. Resources may be intermittently available, and when they are available and you set up something, it seems that that's the way forward and that's what you ought to do, and everybody's comfortable with it. And then suddenly something else breaks, and then everybody's expecting you to do things differently, and colleagues seem indifferent, and everybody says it's getting worse. And it's a very easy narrative to tell that things, are not improvable. Okay, so where do we go from this? And the way it ends up, and this is where I want to tie this in with the burnout slide, we basically end up with feelings of helplessness and depression and anger and isolation. Care may become distracted, less effort goes into it, and there's probably less effort to try and fix things and more enthusiasm for leaving the system. And what can we do? Well, I mean, the one thing is about leadership and role models, and I think we can discuss that to some extent. And I'll open a slide on it just now. But the point really is that leadership and role modeling doesn't have to be the sole responsibility of the person with the highest rank. A lot of this stuff can be done by anybody, and often is done better by folk who on the ground, as it were, as opposed to sitting in offices. Finding a medical community, and Radasa is exactly that, and all the other sort of attempts at and successes at medical community formation are about trying to help people realize that they're doing this thing as a team and as a whole sort of movement of folk working in an area which is challenging but also very rewarding. Then finding areas of agency, and I think this is for me was always been one of the most important one. You can't fix everything, but if you can fix little things and keep them fixed, because they don't stay fixed if you do a little bit and then move on, and that's equally frustrating. You have to keep them fixed. But if you can do that, it is quite worthwhile, and it does help you feel better about the things that are unfixable or just keep on breaking. And it is important to have some perspective too. We are given a gift of being able to help folk, and we can do the best we can where we are. And what the best you can do where you are is not necessarily the best can be done elsewhere, but it is what you get, what you've got. And knowing that and working with it can be quite helpful. So, some of the positives then. We spend a lot of time telling negative stories because they're easy to tell. Colleagues like them. It's almost like social media on steroids. The coffee room is about what went wrong. We underplay what went right. And we seldom actually plan to tell good stories. They have to be really dramatic, or we don't even notice when they happen. Things would often be worse if you weren't there. So it is important to think about what you can talk about that is good stuff. And also, who you praised. Was one of my favorite questions to ask junior staff who were particularly grumpy about something. They were feeling very downbeat. But in fact, part of the process is being able to tell other people that they've done well. You may not feel you have much capacity to do it when you're down, but in fact, it does work even when you're down. If you tell the nurses they did a good job looking after that person with a DKA, who after 2 or 3 days actually does settle down, much to your surprise and delight. And anyone can lead in this. You don't have to be anybody special to do that. But beware of being too positive. I mean, that's obviously the thing that we're all aware of. Acknowledge the negatives. They are there, but a modicum of positivity is not misplaced in any environment. So, what else can you do? I think when we all say things are getting worse here, things are getting more difficult there. But in fact, there are a lot of things that are happening, and some of them are making the system better. If you're positive about things, it is infectious. And if you give that enthusiasm, and we do make a difference. And it is important also to remember that not everybody has the same sort of innate ability to be positive in some situations. If you have it, it's one of the assets you need to share. And sharing it does help. It helps everybody. But strangely enough, you either become toxically positive or a leader if you do that. Neither of which is wrong, but both of them just need watching. And then finally, and I'm trying to be relatively succinct here, so there is time for discussion and thinking about things. Um, yeah, moral distress and self-care. I mean, I describe this as rather like driving on the cell phone. Everybody who does it thinks they are not at risk. Our brains are not wired to recognize when they are distressed, or when they are over engaged with stuff or focusing on one thing to the exclusion of others. And it's important to look for the signs, which are really not being very enthusiastic about what you're doing, feeling sad. Um, Undercaring is relatively well known. Overcaring is actually part of that same thing where you keep on going back to the wards late in the evening just to check that everything's all right and you can't seem to put things down. It's the same sort of issue. So you need to find time to take a break, to chat in a group, to think about constructive and useful ways of managing workload, sharing calls more efficiently, and also look out for your colleagues. Our resilience is all individual, and it's so many factors making up what's affecting somebody at one particular time. You know, if there are family issues as well, resilience is going to have to be shared with other issues, and it's not always as easy for everybody to be equally strong all the time. So look out for colleagues and help them when you can. And it really does make a difference. Sitting for 5 minutes with somebody and saying, "Yeah, it's just tough, but this is good, and we're here to help you, and we can make a plan." Sometimes is all that's needed, and it doesn't take long, and is worthwhile. So I'm going to end off then by just saying that this is a big problem. It's something that's been faced over the world, all over the world. Folk have thought about it, everything from unit-based strategies up to social movements for ethical healthcare, and make the system work better. And all of these things are worth thinking about. You are part of all of them to some extent, and how they work over the next few decades is clearly important to everybody, but don't expect miraculously rapid change. It doesn't tend to happen that way. Slow and steady is probably better and worthwhile. And this is my last slide. And I'm just closing out now. I'm not going to spend too much time on this slide about the actual ethics issues, but more about the moral distress things. The clinical support, resource inadequacies, poor outcomes, and disjunction between what you think is achievable and what actually happens, and the fact you don't have a sense of agency. You can partition workload, you can work smart, you can stand back a bit and think about what you're doing and is it actually the appropriate use of your time. Share it out with others, be positive, reward excellence and in yourself and in others, and be realistic. Share your enthusiasm, but have some safety barriers. And remember, you're a scarce resource. You should be used wisely, um, and look for contacts with colleagues and groups who can help you in all these issues. So I'm going to actually uh, tap out there in terms of the slides, and we can then sit and think about other things that you may or may want to talk about from these, if there is anything. I've covered a lot of ground, and I've done it deliberately fairly fast because I wanted to sort of seed the soil, as it were, rather than dig deep into any one particular issue. But thanks very much. Let's see where we go from here.
Oh, thank you very much, Andy. And I think what I really like about that is with ethics talks, we always think ethics talks is about managing these case scenarios and then coming up with the best plan. But actually, there's no such thing, because the whole point of ethical dilemmas is that there isn't actually a single answer. And it's not about figuring out what is the right thing to do, but it's about the process of how we decide in that particular scenario and how we're going to manage it. And quite often the horse is already bolted. It's no longer as if quite a few of those scenarios you've given. And then how do we do we approach this? And I love this idea, the moral injury framework of emotionally, how do we deal with these dilemmas? And I think the challenge is that if we are burnt out and stressed and we are very anxious or irritable, we are not going to actually be very good at managing these kinds of dilemmas. We actually have to be in the right headspace to be able to reflect and figure things out. And sometimes that is the challenge. I'm going to encourage people to either put their hands up, or you can put either a question or also a comment in the chat if you want. But if there is anybody that'd like to put their hand up and either make a comment, you can either even bring up if one of those cases really resonated with you, or you can also bring up a completely different ethical dilemma, and we can try and see if we can apply some of these principles in terms of how one would manage it. Talking about cell phones, there's somebody in the car with your video on. um, I'm just keeping an eye on the chat. At the moment, there's no hands up. Kariok, you can please unmute and go ahead.
Hi. So I'm a post-com serve. I did my com serve last year in Mpumalanga in a very rural district hospital. So a lot of this resonates very deeply. And I was very much in denial last year, but I was very burnt out and incredibly morally injured to the point I'm still not working and am very anxious about the idea of re-entering clinical medicine. I think it's very difficult because especially of the power dynamic of being a comserve in a hospital where you are the lowest of the order. And in my situation, the vast majority of the MOs and the people senior to us were not practicing medicine that we as comserves considered to be good clinical practice. And we came into many, many problems, as we mentioned. And when taking those problems to seniors or clinical managers, we also found that even the clinical manager practiced medicine in a similar vein. So it became very difficult. And I think especially in that kind of situation, I almost would have I just wish someone had an internship if there had been something about like a module in internship before the end of internship to tell us like what are the things we might experience, how to handle conflict in these situations, how to escalate issues. There were instances where people landed up reporting other people to the HPCSA. We didn't even know that was an option. Like there were big issues and big conflicts. The other thing was that these issues were recurrent in our hospital. The MOs would say that every year the comserves give them a problem. And to me, that was saying, well, if every year the comserves are giving you a problem about the way you practice medicine, then maybe that means you need to look at the hospital and the people who work in the hospital. The other thing I think was, I think just having some sort of like mentorship program or some sort of like support group program or something like that, because it became very negative in a sense that we all, the comserves, would commiserate together, but we were all in the same situation and none of us saw a way out of it because we didn't have anyone who had been through it and who could inform us and support us and give us a way to do something about it. And unfortunately, I think it is quite a common issue. I know quite a few of my friends who also did ComServe last year in rural areas are extremely burnt out and morally injured and struggling with the idea of going back into clinical medicine because of it.
Yeah, I'm sorry that you've had that experience, and I think it is great that you've shared it with us. And it's, as you say, very common. So finding ways forward with that sort of thing, your suggestions are absolutely right. I mean, one does need to have a more nuanced approach to it when you're entering those environments, but they are very, very difficult work environments. It doesn't have to be about healthcare. in any business, if that sort of issues are arising, they can, it's readily recognizable by these leadership and management type folk that things need to be fixed there. The problem is how we fix them. And, again, it comes back to that thing of who leads and from where. And I think that that's something that we should be looking at more closely, is that, sometimes you do need leadership from outside an institution to help it realize um, the fix it's got into, because it is a bit like sort of boiling the frog sometimes. We've always done it like this. It's always been like this. And I suspect that a lot of the folk that you were concerned about were as morally injured as yourself. And that's the trouble with that, it's a very infectious process as people cease to care, as people struggle to do the job. They frustrate other people more, and the end result is a vicious cycle, as you say. So yes, looking for external support and setting up things, and Rudasa and these organisations do have sort of some thoughts on that, and turning it into a thing where the HPCSA gets involved is seldom helpful, because it really just it ends up as my experience of that is that usually the HPCSA will say, yes, there's a problem here, you need to solve it. And it gets dumped back on administration to do so. And it doesn't really get resolved. So we're looking for inventive ways forward would be great.
Yeah, thank you. If I can also add, yes, thank you very much, Cara, for bringing this up. And it's a very vulnerable space that you've stepped into here, and I really appreciate that. And I think also a lot when they're looking at burnout, is one of the things that really contributes to burnout is how powerless you feel in being able to change things. And that is why junior doctors, although we all work hard and we all work under resource restraint, the younger you are, and especially if you're new in a facility or only there for a short period of time, you actually have very little power to make a difference. So also, if you notice things that are not right, or you notice things that are not good, you often can't do anything about it. And as you say, if you then escalate it, you don't have the sort of social credit in that facility to make a difference. So the one thing I can reassure you of what does happen is, as one grows more experienced and more established, and you find a place where you've got a good team where you can work over time, being able to have power, especially in a rural facility where you are only a handful of doctors, you can run your ward the way you want to run your ward, and you can actually introduce trainings and webinars, but that only happens a little bit later down the line. What we are trying to do at the moment, and this is not a quick fix, but which we will hope will eventually filter down, is that postgraduate education is currently going through a massive change where we are introducing something called workplace-based assessment in all postgraduate specialities. And what that involves is consultants and senior doctors, including medical officers, giving feedback, in this case, just to registrars. But what this has meant is that we have identified a real issue with toxic learning environments, and a real issue with the way doctors talk to each other and the safety that there is to bring up problems. So we have noticed that a huge issue also with litigation is young doctors making mistakes, or people doing things wrong because they don't know better. And it's not safe to bring these things up because of the way that these things are handled. And so there's, I think recently also, you'll remember the case last year of the intern with diabetes that was told to come in when they felt unwell and end up dying at the hospital. And these incidents has created, I'm hoping, a little bit of a moral crisis in medicine, that we have to start doing things differently. And although I know we've just started with the postgraduate guys, what has happened is we've now got an amazing training. It's called the Supervisor Workplace Assessment and Teaching Training for anybody who supervises registrars, but it will be extended eventually to start using anyway, if you're supervising interns, students, ComServes, that we need to start changing the culture. and by training our consultants on how to communicate better. So a big part of that training is looking at toxic learning environments and how do we create affirmative learning spaces. A big part of that is really starting to shift the upper echelons, because that's where the challenge sometimes lies. We if I look at the way we were trained when I was at medical school, we have some very, very bad habits as senior clinicians that and we actively need to re-educate. So that doesn't solve your immediate problem. But I would then encourage you, when you get back into medical practice, look out for that, join us even as a trainers, and let's slowly see in our facilities how do we start changing these learning environments that can then become a place where it's easier to manage these ethical things as they come up. Andy, I don't know if you want to raise any last words. I see there's no more hands up and no comments in the chat. I'm going to launch the poll so long.
Yeah, thanks. I don't want to add anything much other than to be slightly positive, and I hope you won't take it as toxic. But the issue really is that, this is our real environment. It is tough, and people are getting hurt in it. But it is still, in my mind, often that the folk who are getting hurt are often some of the biggest assets, that people we want to retain. And as a medical society, we need to be thinking of how to do that. So everybody who's involved in this process and feels strongly and is to some extent burnt out is by definition the sort of person that we really want to have back. So yeah, it's going to take a while to change these things. The fact that they're being recognized and talked about now is probably a very early step, but it'll take a long time to fix. But it doesn't mean we shouldn't start it and keep going. Thank you.
Thank you very much. I'm not seeing any last comments in chat, so I'm quite happy. Yes, we're pretty much well on time. And I can already see excellent feedback here from our poll. Thank you very, very much, Andy, for an excellent presentation. And I think it's actually been one of those where one ends up feeling like, yeah, this is something that there is space for us to grow into, and there are things that can be done and will be done and should be done and all of that. So I appreciate, also did feel hopeful, even with all these ethical dilemmas that we face ourselves. And we do hope to get you involved some more with the ramp and onboarding in the future, just to keep you busy and retirement.
Thank you. It's been great chatting to you guys, and I wish you all the best in your rural block. Enjoy it. It is fun. It is memorable. All I can say is that when you think back 20, 30 years, you'll say, wow, I do still remember all that stuff. And there's probably a reason for that. You were doing a good job. Carry on with it. Thanks, Anne.
Thanks very much. And everybody have a lovely evening, and do enjoy Easter. Eat lots of chocolates, and I hope you're not on call.